Hospital Italiano, Buenos Aires, Argentina. And this work is titled Sequential Transcystic Bile Duct Instrumentation, Postoperative Result in a High Volume Center. I have no disclosure in this work. Cholelithiasis is one of the most common gastrointestinal affection, and that leads to higher healthcare costs. Is most common in Western countries. Its prevalence is estimated to be approximately 15% of the population. 10% of this patient will present choledocholithiasis, and 10% of them remain asymptomatic, and their diagnosis is incidental. There is no general consensus about a therapeutic approach, the best therapeutic approach to biliary lithiasis. One stage approach combining LabCol plus transcystic choledocholitotomy was compared to two-stage approach combining surgical and endoscopic treatment. The objectives is the present study is to analyze the perioperative morbidity and mortality in patients who undergo difficult bile duct instrumentation by transcystic approach. Difficulty was defined by the use two or more methods for some extraction. It's a retrospective study about 742 patients with choledocholithiasis who underwent transcystic choledocholitotomy in the Hospital Italiano, Buenos Aires, Argentina, January 2010 to May 2021. Procedures were classified according to the amount of instrument needed for the lithotomy, has mono or multi-instrumentated. Demographic data and perioperative parameters were compared between groups. A modified American technique of LabCol was employed. In our center, intraoperative cholangiogram was routinely used in outpatient. When the monoinstrumentation with the Dormia basket was not successful, in our center use another one instrument, for example, Cobra catheter, angioplastic balloon, guide wires, or flashing perfusion. Out of 947 patients with choledocholithiasis, in 742, we can possibility performing the one-stage approach. In 19% monoinstrumentated, and in the remaining 20% multi-instrumentated. The indication for surgery, or most frequent reason for surgery, were pain, acute cholangitis, and acute cholecystitis. The demographic and perioperative parameters are similar in both groups. The hospital stay, the rate for retained stone, the postoperative complication, and the needed for choledochotomy were higher in the multi-instrumentated group, and this difference that was significant. But pancreatitis, the multi-instrumentated group was 6%, and in mono-instrumentated 4%. This difference was not significant. Our group already has experience performing sequential transcystic instrumentation, and has published your results in multiple papers in the context of acute pancreatitis, in the context of patient with anatomical change, for example, gastric bypass, and in the context, in an emergency context. And our results are similar, I'm sorry. We have obtained similar results to those reported in literature with two-stage approach and with similar rate of complication. Although the increased morbidity is comparable to two-stage approach, the later has the disadvantage of requiring two anesthetic procedures and increased costs. We believe that in those patients where a difficult extraction is found intraoperatively, the treatment should be individualized. It will be appropriate for prospective analysis of this type of patient to emerge from this research. Thank you very much, and sorry for my English.
Thank you. So we invited Dr. Carlos Padilla to some questions.
Good morning. Congrats for
Thank you.
your presentation. I have a question. In your paper, you said that you have 80% that you decide to explore the transcystic exploration with cholangitis. And in the paper says that you have the possibility of the ERCP
Yes,
in your hospital, right? Most in Latin American, we don't have that access. But I want to ask you something. Why in the cholangitis you decide to explore multiple times the common bile duct if you have the possibility just to do the ERCP, and if it is so hard to extract the lithiasis, you can put just a stent and wait for the cholangitis to resolve and then put in the second stage the cholecystectomy.
thank you for your question. All patients with subset cholelithiasis for biochemical analysis or clinical condition, performing a resonance. In this resonance, selected the patient about ERCP or transcystic choledochotomy. If the patient present a long stone or panlithiasis in the context of or with cholangitis, the treatment is ERCP, but in the context intraoperatoriamente, disculpen, chose the transcystic choledocolitotomy because it's one approach, and that.
You know that cholangitis, you before you put the patient in OR, right?
Yes.
You knew it. Well, for me, it's hard just to imagine that you explore anytime, a lot of time, the common bile duct with a patient that you already know that has cholangitis. Having you the possibility of through the ERCP.
Yes, we have the possibility called to the endoscopy, but I prefer realize transcystic approach.
The second question. You always do the cholangiogram, intraoperative cholangiogram for every cholecystectomy that you do.
Yes, because in our center, the bile duct injuries less to 1% with this method, and the rate of detection, the unsubset cholelithiasis, choledocholithiasis, are 10% approximately. That's all.
Okay. Thank you so much
Thank
for your work.
We continue with the next paper, low resisted index on Doppler ultrasound predict worse graft survival in liver transplantation. The speaker will be Gabriel Lazarotto da Silva from the Hospital Las Clínicas de Porto Alegre. And the discussion was performed by Fabio Costa. Same city. Go forward with the slide. Pointer.
Oh, here, yes. Okay. So good morning, everyone. My name is Gabriel Lazarotto. I am an HPB fellow in Hospital de Clínicas de Porto Alegre, and I'm going to present you results from our group regarding the impact of hepatic artery resistive index on Doppler ultrasound and prognosis after liver transplantation. So I don't have any conflict of interest to disclose. So we know that hepatic artery thrombosis is unfortunately a common complication after liver transplantation, and it occurs in approximately 3 to 9% of all liver transplants, and it is associated with a significant risk of graft loss. In order to detect, in order to screen for hepatic artery thrombosis, most groups use Doppler ultrasound, especially in the first transplant week. And additionally to screening, in addition to screening for hepatic artery thrombosis and vascular complications, it commonly provides the hepatic artery resistive index. So the aim of this study was to evaluate the association of the resistive index on Doppler ultrasound in the first post-transplant week with post-transplant outcomes. So all consecutive patients who underwent liver transplantation from 2001 to 2019 were included. Doppler ultrasound was performed on post-operative day 1, 3, and 5. The resistive index was checked at the hilum, distal to the arterial anastomosis, and the resistive index was calculated according to the standard formula, that is, peak systolic velocity minus end diastolic velocity over peak systolic velocity. Patients were then divided into 3 groups according to the resistive index. So first group is the patients with resistive index below 0.55, between 0.55 and 0.85, and those with a resistive index above 0.85. The primary study outcome was graft survival, both according to the presence or absence of hepatic artery thrombosis and to the category of resistive index. And patients that developed hepatic artery thrombosis were excluded from subsequent Doppler ultrasound analysis. So for example, if a patient developed hepatic artery thrombosis on postoperative day 3, they wouldn't be included in the analysis of Doppler ultrasound for postoperative day 5. So this study included 344 patients, of which 23 developed hepatic artery thrombosis, which represents 6.7% of the cohort. According to the presence or absence of hepatic artery thrombosis, we found no difference in graft survival, although there seemed to be a trend towards decreased graft survival in patients with thrombosis, as would be expected. Possibly the statistical significance wasn't reached, possibly due to small sample size. But patients with hepatic artery thrombosis did have an increased rate of biliary complications. It was 47.8% in patients with hepatic artery thrombosis and 13.7% in patients with no thrombosis. In terms of graft survival, according to the resistive index category, we found that patients with a resistive index below 0.55 on postoperative day 1 had an inferior graft survival as compared to the other groups. No difference was found on Doppler ultrasound on subsequent Doppler ultrasound on subsequent days, on postoperative day 3 and postoperative day 5. We then performed an univariate Cox regression model to identify predictors of poor graft survival, and we found that bleeding, blood transfusion, MELD score, resistive index, low resistive index on postoperative day 1, and the interval between venous and arterial reperfusion were all associated with inferior graft survival. However, when we pulled those variables into a multivariate Cox regression, only the resistive index on postoperative day 1 remained statistically associated with inferior graft survival, suggesting that it might be an independent prognostic factor. In terms of biliary complication, there was no difference according to the resistive index category on none of the postoperative days. So to the best of our knowledge, this was the first study to find an association between a low resistive index, that is below 0.55, and inferior graft survival. The reason for this finding is not completely clear to us. It might be that patients with a low resistive index on postoperative day 1 might be hemodynamically unstable, and it is expected that hemodynamically unstable patients will have poorer results. But it might be also that a low resistive index acts as a surrogate of low hepatic artery flow. And there is a study in the literature showing that.
Sorry, 1 minute.
So there is a study in the literature showing that low hepatic artery flow was associated with decreased graft survival. Unfortunately, we were not able to measure hepatic flow in our study. So in conclusion, our study showed that low resistive index on postoperative day 1 was associated with decreased graft survival. And this study thus reinforces the usefulness of Doppler ultrasound as an important tool in the early post-transplant period. Thank you.
Thank you. Dr. Pio Wetzel, your
Oh, yeah. Yes.
yes.
Congrats for the group. It's an honor for me to debate your paper, because I participated in this group in 1995 until 2000, and then it's an honor for me. It's a very proud for me. Anyway, it's very known that resistance index low is associated with complications of the artery. Then and is if it's really correlated with the complicated artery, it's almost obvious that the graft survival is come down. Can tell me that well, but I took out the persons that had artery thrombosis, but the complications is not just thrombosis. You can have a stenosis of the artery, and the resistance index also comes down when you have portal thrombosis also. Then the question is, what did you do when you had patients with low resistance index? You investigate these patients. Did you correlate the low resistance index with some kind of exams like angiography or tomography, that you can find a kind of complications?
Okay, thank you for the question. Yeah, I think the most interesting finding of our study is that even in patients without thrombosis, the low resistive index was associated with inferior graft survival, and that was shown in a univariate and multivariate model. And I think we should, in patients with low resistive index, even if they don't have hepatic artery thrombosis, we should have a lower threshold to investigate another vascular issue. So in those patients, I think we should have a lower threshold to take them to the CT scan and things like that.
It's important because we can have a partial thrombosis of the porta,
Sure.
or we can have a little stenosis of the artery that this will impact in your survival. And the other point, if you looking for the univariate analysis, you have a different kind of patient, because your patients in univariate analysis had complicated more, because had a MEL more high, the bleeding was so high, and anyway, more other complications that could impact in your survival. What do you think about it?
Yeah, I agree with you. And that's why we performed the multivariate analysis. And after controlling for all those factors that you mentioned, higher MEL score, higher bleeding, higher blood cell transfusion, even so, the resistive index remained associated with inferior graft survival. So, of course, it's only one study, but in my opinion, it suggests that it might be considered an independent prognostic factor in those patients.
Thank you very much. We continue with the next. Right.
Okay, so the next paper is survival in liver transplantation for hepatocellular carcinoma according to Malign criteria, presented by Daisy Gaete from University of Chile, Sede Centro, and it will be discussed by Dr. Wellington Andraus for University of Sao Paulo. Hello, my name is Daisy Gaete, and I'm a general surgical resident at the University of Chile in Santiago. I have nothing to disclose. I will present you our work about survival in liver transplantation for hepatocellular carcinoma within and outside Milan criteria in our center, experience of 14 years. We know that Milan criteria are established for liver transplantation in early stage of hepatocellular carcinoma, and the resulting are 5 years survival of 70% and recurrence rate less than 10 and 15%. The aim of our study is to assess the long-term result in survival among groups according to Milan criteria. This is a prospective core study. We enrolled patients with HCC transplanted between 2006 and 2020, grouped according to Milan criteria, based on explant findings on biopsy. We enrolled 100 patients. The median age was 62 years. We have 71% of men. And the mean etiology of cirrhosis was non-alcoholic steatohepatitis with 47%. Hepatitis C or B virus with 23%, and alcoholic with 11%. We follow up for 56% a month. In the first 90 days, and we have median of intensive care unit was 4, total hospitalization days was 17, and we have complication according to Clavie and Dindon for 8% for type 3, 28% for type 4, and the operative mortality was 5%. For the analysis by group, we excluded 13 cases because they have 100% of necrosis on biopsy. So we have 2 groups, one within Milan criteria with 62 patients, and other group with outside Milan criteria with 25 patients. The population of both groups are similar in the characteristics, so they are comparative. And with the pathologic characteristic, we have percentage lymphovascular permeation. In the group of within Milan criteria, there are 21%, and in group outside Milan criteria, there are 44%. Finally, the long-term results. We have 5 years overall survival in the group within Milan criteria of 75%, and in the group outside Milan criteria, 63%. That is a significant difference. And in the recurrence rate, 5 years recurrence rate, we have 3.5% within Milan criteria and 24% in the group outside Milan criteria. It is a significant difference too. So we conclude that in our center, the liver transplantation on HCC patient, we have a good result with a 5-year overall survival greater than 70%. And in patient outside Milan criteria, we have a decrease in survival, but it's still greater than 60%. Thank you very much.
Congratulations for work, your paper. I think it's a a very good data. Was already published in other countries, but it's very important to have data from our own in Latin America, showing that we pay a bigger price if we go further in HCC. So I think it's very important. I'd like to highlight some factors. First of all, it's interesting the etiology you showed us. So in Chile, you showed 47% of NASH since 2006. It's quite high. It's higher, maybe it's higher than the US, and for sure it's higher than in Brazil. And I thought this is interesting, you know. And only 11% of alcohol is much less than the other countries, less than published series. I think in US and Brazil, it's more than 20%. And I'm wonder why. I don't know, maybe we appreciate more Chilean wine than yourself. I don't know. But another thing is, I congratulate you for your very good outcomes. You have a very good survival, long-term survival rate. But I think you could go deeper in your data and found subgroups of your patients. For example, analyzing the biology using your data, your alpha fetoprotein, your biopsies, and found if this patients outside Milan, for example, they behave differently, the subgroup well differentiated and not well differentiated, or alpha fetoprotein. So we could compare both those groups. I don't know if you have this data you analyzed before, or you have it in mind. If you can answer.
We analyzed that data, but finally, the main difference is the recurrence. This is the principal factor to impact the survival in our patients, not the biology's characteristic of HCC.
Okay, I see. Maybe because the N,
Yeah,
the number was not very high. Huh?
yeah.
But maybe you could put in your slides. It's interesting to show.
Okay, thank
So-
you.
Congratulations once again.
Thank you very much.
Short and very short.
We will allow one more question that someone.
Very short question and more very short answer.
No, I wanted to congratulate you overall. It's not really our question, because I know how hard it is to put yourself out there and speak in another language that's not, your primary language. Also congratulate you because it's a lot of work. Like, I mean, you're in clinical work and you're doing research, so it's a lot. I'm very impressed by what you're doing. And again, in looking at your results, this is not a question, but I thought there was like a very minimum amount of women in your cohort. So I'm wondering if you could potentially look into what's happening out there. I'm no like HPV surgeon at this point whatsoever, but I thought it was like the cohort was a little bit, I don't know. So I'm wondering if more men are getting into your institution and women are not getting referred as much. So again, like looking at disparities, I think it would be like the interesting for you, but congratulations overall. That's what I wanted to say.
Thank you very much.
Thank you so much for your work.
Thank you very much. The next paper is the definition and outcome of postoperative biliary fistula after bile duct injury repair surgery. The speaker will be Gabriela del Ángel Milán from the Instituto Nacional de Ciencias Médicas Institución Salvador Subirán, Mexico. And the invited discussion will be Cecilia Geren from Peru.
Thank you very much. Good morning to everybody. First, I want to thank the association for choosing my paper for this section. We were talking about, can we start the presentation?
Yes.
The one.
Sorry.
Yes.
Yeah. So we will be talking about definition, management, and outcomes of postoperative biliary fistula after bile duct injury repair surgery. First, I have no disclosures. And as a background, let's remind that bile duct injury still has remained constant since the introduction of laparoscopic cholecystectomy. And it has been reported from being 0.08% to 0.5% in most of the series. Usually, when it's a complex bile duct injury, it usually requires interventional or surgical procedures to restore the biliary tract. Most of the times, it's an hepatico-jejunal anastomosis, but in some complex cases, even a portoenteral anastomosis is needed. Biliary fistula has been reported in these cases from being to 0.44% to 8%. So it raises the question, how do we define biliary fistula? But most important, how do we manage it? And how do we decide when we're going to be more aggressive in the treatment than conservative treatment? So as a background, the definition that we count right now, it's as an increased bilirubin concentration that it's more than 3 times the serum concentration in the intra-abdominal drain or within biliary collections measures at the time. There are 3 grades, that it's grade A, having no clinical impact, grade V, that it's more than 7 days, are having the need of any intervention, and grade C, that is when you need some type of surgery. Just the most important part of this definition is that this definition was described being part of a post-hepatectomy group or even in pancreatic surgery. But this definition was not described being in bile duct injuries. And let's remind that bile duct injury cases most of the times have impaired healing, have bile duct ischemia, inflammation, and irregular margins. So the objective of this study was to describe the frequency, management, and outcome in patients with postoperative biliary fistulae according to a definition that we described in our center. The definition that we made was clinically relevant biliary fistulae as an output greater than 100 milliliters per day after postoperative day 7. We review all patients that have underwent a bile duct repair surgery since 1996 to 2022. Patients with incomplete medical record were excluded. So in order to get an idea of how was the clinical impact, we compare patients that have described some clinical relevant biliary fistula versus patients with no fistula. We review demographic, clinical data, management strategies, and outcome. And also, we analyzed inflammatory and nutritional indicators. Just to get an idea if this kind of affected the presence of a clinically relevant biliary fistula. So we analyzed preoperative albumin, the neutrophil lymphocyte ratio, body mass index, and the prognostic nutritional index. We reviewed patients from 1996 to March 2022, and we get to have 802 patients. From this group, 36 patients developed a clinically relevant biliary fistula. It's important to mention that these patients were found to be older, having more smoking habit, having more diabetes mellitus, arterial hypertension, and other comorbidities. It's important to notice that there was no difference between the type of bile duct injury or the type of repair between the both groups. And also the albumin, the preoperative albumin level, it was higher in patients that develop a clinically relevant biliary fistula. From other outcomes that we have during the follow-up, 12 patients of the whole group with a clinically relevant biliary fistula developed some kind of dysfunction. This was presented as cholangitis or even documented bilioenteric anastomosis stenosis. We also found that these patients had more viloma, of course, and they had the more need of a placement of a transanastomotic drain. They also had more reoperation in the whole follow-up period, that it was 47.2% versus 17%. And when we analyzed the reoperation rate in the first 30 days, it was also higher for the group having a clinically relevant fistula in 19.44%. This is important because this higher need of a reoperation was most of the times because it was a need to control the fistula. The postoperative mortality was also higher in patients with a clinically relevant fistula, being 5.5% versus a 0.8% in our whole group, and having a Knox ratio of 7.75. The patency at the first year of the anastomosis was achieved in 7.4% of the patients that developed a clinically relevant biliary fistula. And this was what I was telling you about the reoperation, that being even analyzed in the first 30 days, it was also higher for this group. So highlights of this work. The bile duct injury is a very specific scenario. So the clinically relevant biliary fistula is a definition that needs to be adequated, and it's probably not the best definition that we have using the same that hepatectomy and pancreatic surgery. The nutritional and inflammatory markers, even if we did not find any difference in this group, it's also important to remind that most of these patients have lower albumin levels because they have a chronic inflammation setting. So as we know, right now, the state of art of this type of surgery is to having the best nutrition and the best optimized level of inflammation before going to a surgery. Using our definition of clinically relevant biliary fistula, we can state that even in short term, we're going to have a higher morbidity and a higher mortality. And even in mid and long term, almost a third of the patients are going to have dysfunction of this anastomosis. So our conclusion is that the definition of biliary fistula greater than 100 milliliters in postoperative day 7 is going to represent a clinically relevant scenario. And most of the times, radiological intervention and reoperation are going to be needed. Using this definition, we're going to have a low incidence, at least in high volume centers of bile duct repair surgery. The cause of a clinically relevant biliary fistula is going to be multifactorial, and patients with clinically relevant biliary fistula are going to have a higher incidence of postoperative bilioma and postoperative mortality. And finally, I want to thank Dr. Miguel Mercado for his lifetime work and collaboration to this project, to our research interns that have helped us in every step of the development of this project, and to all of my mentors of the Latin American HPV Fellowship, because they're really committed with our development as HPV surgeons.
Thank you.
Thank you for your presentation. Dr. Cecilia Geren.
Okay. Excellent presentation about this topic. You present a new definition about clinically relevant biliary leak, and you present is necessary more than 100 milliliters of 7 days. And moreover, you present associated to as risk older age, diabetes, arterial hypertension, and you know that the classical definition, the group of liver surgery present the cutting is 3 days. Then the question is, why do you group propose that the cutting is the 7 days? Because there are some days, the 3 days, 7 days. Because I know there are conditions as an ischemic condition or technical mistake. The patient present comorbidities and associate complication as 3 days. On the other hand, the question is, why do you prefer that cutting the 100 milliliters? Because at least at 100 milliliters, there are 2 complications. It's possible a biliary complication, for example, peritonitis biliary and adhesions. It is important, the management before than 7 days, before than 100 milliliters. And finally, I would like, what happened with the albumin level? Because in this group with the most biliary leak, the albumin is higher than the group without the leak.
Thank you very much. Dr.
Sorry,
Castillo.
but you have less than 1 minute for your answer.
I'm going to be fast. So we chose 100 milliliters because it represents the drainage of 2 segments. And what we're stating is that if we wait more than 3 days, probably most of the cases are going to resolve alone. So that's why we are choosing clinically relevant biliary fistulae as 7 days, because if the leak persists after 7 days, it's probably we're going to need some intervention. That's why we chose this kind of definition. The other question about the albumin, it's probably because these patients, as they're chronically inflamed, we supplemented more albumin in these patients. But we have to remember that this is not such a good marker in these patients because it has 21 days of life from the albumin. So probably if we were supplementing the level that we have preparative, it was not really representing the nutrition of these patients. So I think the opportunity here is that for patients that for people that we treat, a lot of patients with bile duct injury, is that we should get more attention in the preparative nutrition, as well as treating the inflammation so that we can have better results in the end.
Thank you very much.
Thank you very much for your work. We will move on to the next work, preliminary results, development of pancreas PDX models to test new therapeutic strategies, presented by Emilia Moreira from Uruguay, and it will be discussed by Dr. Gustavo Cohan from Argentina.
Hi, my name is Emilia Moreira, and I'm here to present our preliminary results on development of pancreas PDX model to test new therapeutic strategies. This study was funded by the Americas Hepatopancreatobiliary Foundation with the Latin American Investigator Grant. Pancreatic cancer is number 12 in incidence and 7 in mortality, and it will probably escalate to the 4th position by 2040. Even though there's been major breakthrough in the last few years, its prognosis remains poor. This is probably related to the aggressiveness of the tumor and its late diagnosis. We are working on immunotherapy and oncolytic viruses. We designed a chimeric antibody that recognizes the TN antigen that is only present in tumoral cells and not in normal cells. This chimeric antibody will be useful to deliver chemotherapy and also to activate host cells to attack tumoral cells. And we modified the Coxsackie B3 virus to be able to replicate inside tumor cells and leads to its destruction. The objective of our study was to generate at least 10 PDX pancreas models and to start to test the new therapeutic strategies. The inclusion criteria was all the patients treated in our hospital with potential pancreatic adenocarcinoma, and we exclude all the patients that received previous chemotherapy. The samples were taken either from the surgical piece or from throughput biopsy. We implanted the samples subcutaneously on NSG mice. We selected to do it subcutaneously because for start, it is an easier procedure, and it's also easier to monitor its growth. NSG mice are the most immunodeficient mice. They lack mature TMB cells. They are deficient in multiple cytokine pathways, but they keep neutrophil activity. These are the cells that we aim to activate with our antibodies. And we characterize our antibodies with immunofluorescence and immunohistochemistry, and we also isolate the RNA purified from the Coxsackie B3 virus, and we quantified it. Here I summarize the characteristic of our patients. We register its age, previous conditions, bilirubin levels, tumoral markers, and we also characterize the tumor, its location, its size, positive lymph node, metastasis, and the stage of the disease. 3 patients underwent resective surgery, and 4 patients died either from disease progression or from infection. We obtained 3 PDX models. 2 were from pancreatic cancer, and 1 corresponds to a pancreatic metastasis for colonic cancer. We had a successful rate of 27.3%. On the left image, you can see how we handle our mice. We use a strictly pathogen-free environment with a laminar flow chamber to avoid infections. And on the upper right side, you can see a mouse that has a tumor around 1 square centimeter. Once we reach that site, we resect the tumor, we fraction it, and implant it on successive mice generations. Here, we evaluate the activity of our antibody. The first images correspond to immunofluorescence. We use a secondary antibody with an immunofluorescence marker that binds our chimeric antibody. On the first 3 images, we have different expressions of the immunofluorescence markers because different cells express different amounts of TN antigen. And the 4th image corresponds to normal cells that, as you can see, there is no immunofluorescence marker expression. And on the second line of images, we have a tissue microarray for pancreatic cancer. We incubated with the aminobenzidine that precipitates on the site where our secondary antibody binds our chimeric antibody, and it changes color to brown. And here we evaluate the activity of our virus. We use 3 different cell lines. MRC5 is a normal cell line, and H1975 and A549 are tumoral cell lines. As you can see, either on the microscope images or in the culture images, the virus doesn't affect normal cells, even on high concentrations, up to 10 viruses per normal cells. And when we put it with tumoral cells, it destroys the cells even with low concentrations. Different papers report a successful engraftment between 20 and 80%. Even if our rate is low, it is between the percentages described. We think that our low percentage is related to the distance between our hospital and our laboratory, that it is about a 30-minute ride. And it is known that a cold ischemia period longer than an hour impacts negatively on the engraftment. We hope to improve our times in the future. And we think that it's also related to the small tumor samples, as more than half of our samples come from throughput biopsy. In conclusion, in our first year, we successfully obtained 2 pancreas PDX models and 1 colon PDX model, and we're on the way to optimize our antibodies and our oncolytic viruses. And once we reach 10 PDX models, we will start testing the therapeutic strategies. And for the future, we hope that once we reach an acceptable percentage of successful subcutaneous engraftments, we will be able to do orthotopic engraftment that will reproduce more accurately the tumor physiology, and that will also lead to improve our imaging methods to monitor its growth. Thank you.
Thank you very much for your presentation.
Emilia, congratulations for the presentation. It was really nice. I know how difficult it is to perform these sort of studies in our countries. And I think that the future of the PDAC treatment will be immunotherapy. So I have 2 questions of your presentation. The first one, you reported 27% of implantation rate. To what you attribute this low rate? And I want to ask you if you use some matrix like Matrix Health to perform the implantation of the graft in the mice. And the second question is, how can you ensure that the antibody gets into the cell? Because the immunofluorescence shows you that the antibody is bounded to the antigen, but you're not sure it's inside the cell.
Yes, we use a matrix to increase the percentages of success, and maybe we can work on that to choose a different matrix to increase even more our successful rate. And I'm sorry, can you repeat the second question?
Yes. How can you ensure that the antibody gets into the cell? Because immunofluorescence shows that the antibody is bounded to the antigen, but we are not sure that the antibody gets into the cell to take the drug or the virus.
Yes, TN antigen is a membrane antigen. So we don't actually look to it, to our antibodies to get into the cells, but to bind, for example, the neutrophils to attack the tumoral cells, or to achieve the chemotherapy to arrive to the cells and perform a therapeutic action. But it's not actually the antibody that performs the treatment, but it facilitates other treatments.
Okay, thank you very much.
Thank you.
Thank you very much. We will move on for the last paper, early vital injury repair, all-in-one minimally invasive approach, presented by Dr. Melissa Amondarain from Hospital Italiano Regional de Sur Bahía Blanca, Argentina, and it will be discussed by co-moderator, Dr. Mariano Jimenez.
Okay, thank you very much. Good morning, everyone. My name is Melissa Mondarain. I'm from Hospital Italiano de Bahía Blanca, Buenos Aires province in Argentina. Thank you to the HPV authorities for this opportunity. No disclosures. You can start the video.
Please. Okay.
Early bile duct injury repair, all-in-one minimally invasive approach.
Present a clinical case of a 50-year-old male.
Has audio.
A laparoscopic cholecystectomy was performed 5 days earlier. Intraoperative cholangiography was
Can we start it
performed.
over again?
The surgeon didn't record the surgery.
The video, sorry.
He is early bile duct injury repair all-in-one minimally invasive approach. Present a clinical case of a 50-year-old male. A laparoscopic cholecystectomy was performed 5 days earlier. Intraoperative cholangiography wasn't performed and the surgeon didn't record the surgery. He is referred to our center for presenting jaundice with cholestatic pattern. We observed dilatation of the intrahepatic bile duct with lack of continuity of the common bile duct in the proximal third, where the presence of surgical clips stands out. Anatomical changes and post-surgical modifications are recognized with the absence of the gallbladder, highlighting the presence of some air bubbles and laminar heterogeneous liquid into the surgical lodge. After the administration of intravenous contrast in the arterial phase, surgical clips are observed that obliterate the cystic artery. Hepatic and right hepatic artery indemnity stands out. Laparoscopic approach is performed, where there is evidence of a surgical site with an hematoma in the gallbladder lodge. The hepatic hilum is explored, achieving a clear vision of what appears to be the cystic duct. Catheter is placed to perform cholangiography that shows a narrowness in the common hepatic duct with a good distal passage. The images that stenose the bile duct appear to be clips, so they are searched using radioscopic guidance. Once they are found, they are removed. On removing them, there is no narrowness or leak site evidence. At this moment, it's decided to perform a rendezvous technique. We leave a biliary plastic stent. Cystic duct is closed with metal clip and a PDS loop. Cavity cleaning and vacuuming. Drainage is left. The patient evolves favorably and is discharged from hospital after 58 hours with a normal hepatogram.
Well, here is the last picture of the cholangiography where 4 months after the surgery, we removed the stents. That was 2 weeks ago. So this is continuing. Thank you very much.
Thank you.
Thank you for your presentation. Well, first is clips create the false images in the bile duct during the cholangiography, resonance cholangiography. For that reason, the CT and the complementary, the MRI is very useful in these cases. First, the second thing, well, I love the rendezvous techniques and minimally invasive procedures, percutaneous or endoscopic, in the treatment of the bile duct injury. And in this case, one possible and several centers in the world use in bile duct injury directly treatment endoscopic or percutaneous without laparoscopic or open. I don't understand, and my question is, your centers, your endoscopies introduce one plastic stent
Yes.
alone.
Alone.
And it's really, the result is amazing, but it's very, very uncommon, the dilation with only one plastic stent. Is the two techniques more common in the world is or balloon dilation or better sustained dilation with multiple plastic stents. This result with only one stent, and really is fantastic, but very unusual. What is the reason in your idea of this incredible result with only one plastic stent?
In fact, we decided to do this because was an early repair 5 days after the main surgery. And we decided to leave the stent for months, and we'll see.
Okay. It's possible in some center when you come to the surgical time is performed directly one surgical repair and not this, because at the end of the day, when you introduce the guide wire through the cystic duct, only was the possibility to obtain better papilla cannulation with the endoscopy, but no more than this, because at the end of the day, the stricture was crossed for the endoscopies alone. Well, but congrats for the video. Thank you very much, all. We finished 1 minute before. I'm very proud.
Thank you, everyone.
Yeah.